Next, we're going to switch and talk about some more of the other therapies for atrial fibrillation. And my friend and colleague, Dr. Paul Friedman, is going to join us for this. Paul really helped design this entire electrophysiology day and has been kind of running this whole day for the last number of years. He's the director of the EP board review course here. He's the vice chair for the division of cardiology. He's in charge of all of Mayo Clinic's activities around developing a business plan for remote monitoring. What else should I say about you? I said too much already? All right. So what we'll do, Paul's got a couple of pre-questions, and then he's going to get to these cases during the course of his talk, and then we'll ask some questions at the end of it as well. So the first case is a 57-year-old man with hypertension with 8 months of highly symptomatic AFib. Flecainide failed. You can see the episodes at 1 to 2 per week for a few hours. He's on atenolol, normal blood pressure and heart rate now. Blood work is normal. EF is good except for mild LA enlargement. What's the best treatment option for this man? Propafenone, disopyramide, amiodarone, or left atrial ablation? Okay. Number 2, 63-year-old woman presents with shortness of breath on exertion 1 month after her pulmonary vein isolation. You recommend reassurance, a CT scan, a sniff test, a pulmonary angiogram, check her INR, or admit her for operation. And the next one is a 54-year-old, otherwise healthy woman presenting with 3 highly symptomatic episodes of AFib, all terminated spontaneously. Current ECG will be on the next slide. Plans are made to start Flecainide. Which asymptomatic ECG finding is most likely to develop that would require discontinuation of the Flecainide? QT going to 460, QRS going to greater than 120, PR prolonging to greater than 200, or the heart rate dropping to less than 60.
Go to the next slide.
An educational opportunity. All right, so Paul, thank you for being here. And for those of you so Paul will do kind of what Nish and I do on the other days, and coming back from breaks early, he'll show you unknown tracings and those kind of things and talk you through those after each of the breaks throughout today. So Paul, thanks for being here, and tell us how we're going to treat AFib.
Great. Thank you. It's a great pleasure to be here. I think all of us in practice see a lot of atrial fibrillation, and my goal over the next few minutes is just to review what the guidelines and current data suggest so that all of us can be updated to the top of our game. In 1 or 2 slides, I changed the order by 1 slide. I don't want to throw anybody off. That's just I put a question and information in the middle of the talk in a reverse order. So you'll come across that. Otherwise, I think we'll follow everything exactly as is. It's good to step back and think about the classification of atrial fibrillation because it informs treatment. And the guidelines describe paroxysmal atrial fibrillation as atrial fibrillation that terminates spontaneously or with intervention within 7 days of onset. Episodes may recur and there can be variable frequency. If an episode lasts for a week or more, for 7 days, then it's considered to be persistent. And we differentiate that from long-standing persistent when it's been present for 12 months. Permanent atrial fibrillation is present when there's been essentially a joint decision to not take any effort to restore normal rhythm. So these will guide some of our treatment decisions. We've already heard about non-valvular atrial fibrillation as it's described in the guidelines very crisply. If you want to see an excellent article reviewing non-valvular atrial fibrillation, John Cam reviewed the data behind this, which I think can be informative. But for the purpose of boards, this is what you need right here. Absence of rheumatic mitral stenosis, or a mechanical or bioprosthetic heart valve, or a repair would be non-valvular atrial fibrillation. If the atrial fibrillation is paroxysmal, the strategy we generally select is rhythm control. If it's permanent, then by definition, we're deciding on controlling the rate. If it's persistent or long-standing persistent, then we look at other clinical considerations, and I'll come to those in a minute in terms of deciding how we approach the arrhythmia. Now, it's good when we talk about rate control to describe what it is. This has been formally studied in a prospective randomized trial in which strict rate control was described as a resting heart rate of less than 80 beats per minute or a heart rate less than 110 during moderate exercise. Lenient rate control is defined as a resting heart rate that's less than 110 beats per minute. And it turns out from the RACE-2 trial and consequently in the guidelines that if we endeavor to obtain strict rate control, there was no benefit compared to lenient rate control. And indeed, it took more effort, more clinic visits, more medication adjustments to achieve strict rate control. So if asked, in general, a resting heart rate less than 110 is acceptable as long as the ejection fraction is at least 40 and there are no symptoms. We need to monitor LV function, and in practice, for any deterioration in LV function, we would consider being more aggressive, either with rate control or switching to rhythm control. So what medication do we use for rate control? Well, if you look at the guidelines, we consider whether the person has other cardiovascular disease or not, if there's hypertension or heart failure with preserved ejection fraction, left ventricular dysfunction or COPD, and yet if you look across all the options, essentially it's beta blocker and diltiazem or verapamil for any of these conditions, the exception being in ventricular dysfunction, where we would select beta blocker and digoxin. If these strategies fail, then amiodarone is a very effective rate control drug, but in practice, it's rarely used for that purpose outside of the acute setting because of the long-term comorbidities that you'll hear more about later. A few key points with regards to medical rate control. The key, of course, is to think about the comorbidity, as we would in practice. So if we're dealing with a patient with hyperthyroidism, where beta blockers are part of the treatment, or someone who's just had surgery, or someone who's in the throes of an acute MI, or with chronic, and let me underline the word chronic heart failure, then beta blockers are the preferred agent for rate control because it will serve two masters. Calcium blockers are particularly useful in COPD. Remember, that's verapamil or diltiazem, and that also remember, importantly, nifedipine, amlodipine, and felodipine do not slow AV nodal conduction. If you give these drugs, you may get a faster heart rate due to a reflex tachycardia from lowering of the blood pressure. Digoxin is useful in heart failure. It is actually contraindicated as a sole agent in paroxysmal atrial fibrillation. Now, why would that be? When you think about how digoxin works, it promotes vagal tone. And in someone with paroxysmal atrial fibrillation, they're frequently sympathetically driven, and so this drug tends to be extremely ineffective. You're trying to modify tone, it's overpowered by the changes in tone, and due to its ineffectiveness, the guidelines had contraindicated it. It is useful with amiodarone in heart failure in the absence of Wolff-Parkinson-White. Now, one of the things that may come up that are frequently difficult are managing the rate in congestive heart failure. So here, digoxin is frequently used, and remember the optimal levels are 0.5 to 0.8. It's also important to remember that a patient's heart rate at rest may not accurately reflect their rate control when they're active, especially again with digoxin because you're promoting vagal tone. They get up and exercise, and there's a shift to sympathetic tone, a withdrawal of vagal tone, and you lose rate control. We already mentioned the roles of beta blockers, but if someone has decompensated heart failure, obviously it's difficult to administer beta blockers. And amiodarone is useful in the acute setting for rate control in a patient with heart failure. When drugs fail, AV node ablation is extremely effective. It has a more than 99% success rate in terms of ablating the AV node. And remember, the concept, of course, is that the fibrillation is happening in the atria. We ablate the node, which prevents these rapid impulses from propagating to the ventricle. About 3/4 of patients will have a slow junctional escape, typically in the 30s or low 40s, but a few patients will be pacemaker dependent. And by definition, that means if we turn the pacemaker rate down to 30, which is the lowest rate that most pacemakers go to, and observe the patient at that rate for a minute, they won't have anything but paced beats. Now the reality is if the pacemaker were to fail, they could have a heart rate of 28, but we wouldn't see it. So that's the definition of pacemaker dependency in about a quarter of patients. It improves symptoms because patients are getting off of a lot of medications, all of the rate control medications. Importantly, if the ejection fraction is less than 45%, then the guidelines indicate CRT is indicated at the class 2B level of C evidence guideline. Now, the reason for that is as follows. If we pace someone chronically from the right ventricle, what morphology will their ECG have? It'll be a left bundle branch block, right? When you have left bundle branch block, you activate the right ventricle first because during sinus rhythm you can't propagate to the left ventricle. Another way to think of it is the lead V1, which is what we look at for right or left bundle, sits on the right precordium. Following the basic principle, if you're moving away from a lead, you're negative, towards a lead, you're positive. The right ventricle sits right behind the sternum. We all know that from chest x-rays. If you start in the right ventricle, you're moving away from V1, left bundle. And what that means is there's delayed in the lateral LV wall activation. And so you have dysynchrony. And so for patients with even mild left ventricular dysfunction, if you're going to chronically be pacing, then CRT is warranted. Guidelines indicate for chronic AF, no need to put in an atrial lead. If it's paroxysmal, then a dual chamber device can be used to track the atrial rate during episodes of sinus rhythm. Atrial fibrillation will continue to exist in the atria, so anticoagulation is needed. Now, importantly, in someone who's had rapid rates from atrial fibrillation, when we first do an AV node ablation, we will typically pace at 80 or 90 beats per minute. Now that's a pretty fast rapid pulse. Why would we do that? If you think about what happens if you're rapidly dropping your heartbeat from 100, 110, 120 all the time down to 60, the QT interval is a function of the heart rate. So you'll actually get QT prolongation. And if you drop too rapidly, too far, there's a tiny risk of proarrhythmia, ventricular proarrhythmia, torsade de pointe. So typically then after an AV node ablation with rapid rates, we pace at 90 beats per minute for a month, then 80, then 70, and then down to 60. And that has eliminated that problem. When to restore normal sinus rhythm? Well, first, if symptoms of atrial fibrillation are present despite rate control, well, then we need to do something else. If we are unable to control the rate with rate control agents and an AV node ablation is not desired, then we restore sinus rhythm. There are other considerations. Younger patients, often we consider a more aggressive approach towards sinus rhythm. In atrial fibrillation, I suppose young is anyone under the age of 65. Tachycardia-induced cardiomyopathy, if it's a first episode of atrial fibrillation, and particularly if it was caused by an acute illness where we think that the trigger driving the atrial fibrillation may resolve, or if the patient has a preference. So these were the middle two categories where there's more judgment involved. So let's go to this case. 57-year-old man with borderline hypertension, 8 months, highly symptomatic, Fleckinitis failed. It's the one that you saw at the beginning. So you can see his blood pressure is well controlled, EF is normal. What is the next best treatment option? And let's go ahead and vote on this one again. Great. So he's a patient who's failed flecainide, and as we'll see and review according to the guidelines, once you've failed an antiarrhythmic drug, especially if you have a normal heart, then ablation is very considerable, and I'll show you some of the reasons why that is. The basic concept for the pathophysiology, and I'll go over this somewhat quickly since I believe Malini covered it somewhat, is that the pulmonary veins have muscle bundles within them. And if you looked at the vein, you wouldn't see discrete bundles, but histologically, there are these preferential bundles of conduction. And they have an effective refractory period that's shorter than the rest of the atrium. What that means is they can fire more rapidly, and in some people they do. And they discharge so rapidly that the remainder of the atria can't keep up synchronously. And if we take a loop catheter and place it within the vein with electrodes configured in this circumferential manner, and in this case, we're pacing during normal rhythm, we see this long delay, and then we see these spikes. So there's something at the junction that in most people separates the rest of the atria from the veins electrically. But if you had a connection here, then this very rapid discharge, if it were happening, can come out. And here's an example from a patient, and it's busy, but let me just walk you through because it shows one or two key points I want to highlight. On the surface, all of us would look at this, and if you can see it back there, you would agree that this is atrial fibrillation. And if you look, here's the high right atrium and the coronary sinus. These are all very fast atrial rhythms. And this is the catheter within the pulmonary vein. And if I asked you which is firing more rapidly, the pulmonary vein or the high right atrium of the coronary sinus, you'd say pulmonary vein. And so this concept, what's going fastest is probably driving the rest, is this core EP concept. And what we did was we delivered a few ablative lesions around the ostium of the vein. And look what happened here. The surface is normal rhythm. The atrium on the right and on the left are normal rhythm, but the vein is still fibrillating. And every electrophysiologist will have had one case like this at some point in their career, really highlighting that in paroxysmal early atrial fibrillation, these veins fire rapidly, and they just cause the rest of the atrium to trigger. And if you can separate the veins from the rest of the atrium, then you may eliminate atrial fibrillation in paroxysmal atrial fibrillation. And as there's more hypertension, advancing age, diabetes, fibrosis, inflammation, then it becomes a more widespread disease and there's more tissue involved. There have been a number of trials that have randomized patients to drugs or ablation, and here you can see the odds of freedom from atrial fibrillation at 1 year strongly and consistently favoring ablation over antiarrhythmic drugs. And here you can see the risk of cardiovascular hospitalization favoring ablation significantly over antiarrhythmic drugs. So this has informed our guidelines. There's one critical piece of information that's not shown on these slides that in practice I think all of us are aware of, and that's the following. The age of these patients in these trials was 55. And if you look across the ablation practice, it's really been applied broadly to patients under roughly the age of 65. So that as we start dealing with older patients with more persistent arrhythmia, I think that's where we start getting into more of the decision point and why the guidelines favor rhythm control and more ablation towards the younger patients. We have the best evidence there for that group. So what do the guidelines say? Here's the summary. No structural heart disease. If it's paroxysmal, you can go straight to catheter ablation if you and the patient feel that's the appropriate choice. If the patient doesn't want to, you can use almost any antiarrhythmic drug except for amiodarone. We keep that in reserve because of its organ toxicity. One key thing to remember when selecting drugs, that is no dronedarone for persistent atrial fibrillation. In the PALACE trial, patients with persistent atrial fibrillation were more likely to die if they received dronedarone. So we don't use that for persistent atrial fibrillation. And there are other data for heart failure, so it's not one of my favorite agents. You have to be a little careful about when you select it. Commonly, with no structural heart disease, flecainide and propafenone are often our first choice agents. Now, if someone has structural heart disease, if they have coronary disease or heart failure, for the heart failure patients, amiodarone and dofetilide have consistently been found to be safe. They don't increase mortality, and they're effective compared to placebo or other antiarrhythmic drugs for that matter. So heart failure is amiodarone or dofetilide. Again, heart failure, amiodarone or dofetilide. Stem of a question, patient has a low AF, amiodarone or dofetilide. None of the other drugs. For coronary disease, we have a lot more flexibility. The guidelines recommend dofetilide or sotalol. Remember, sotalol is a beta blocker that has a little extra punch to it, and so it makes sense to give a beta blocker to patients with coronary disease. May also lower their blood pressure a little bit if they're hypertensive. If it's paroxysmal, you can certainly consider catheter ablation, although depending on the amount of structural disease, these patients are more likely to have a drug first. And remember the warning about dronedarone. Persistent, no dronedarone. Post-op care after an atrial fibrillation ablation, recurrent arrhythmia can happen, and it happens in an important subset of patients. And why does it happen? We see it after a Mays procedure as well. Well, right after the procedure, number one, an ablative lesion may be 5, 6, 7 millimeters thick. How thick is the atrial wall? Many of you look at it on echo all the time. It's 3 or 4 millimeters. So we often get pericardial irritation or pericarditis. There's a lot of emerging evidence, and I'll have that in a summary slide, on colchicine to prevent that. So the pericarditis, increased catecholamines, maturation of lesions, for all these reasons, typically we avoid reablation in the first 3 months. So if someone has an ablation, they see you 2 weeks later, they're back in atrial fibrillation, what's the move? Treat them with antiarrhythmic drugs, restore normal rhythm, allow healing and reverse remodeling of the heart. And depending on the series you look at, 15 to 45% of patients will get a second procedure. That broad range in part reflects that the series include paroxysmal and persistent patients. And those who are persistent, of course, are far more likely to need another procedure than paroxysmal patients. Now, what about this case? The 63-year-old, I'll ask you to vote in just a minute, but not yet. Just look at this x-ray. What is the abnormality here? Because that will inform what we're going to do. What looks funny in the x-ray? So look at the difference between these two hemidiaphragms. We normally expect the right hemidiaphragm to be a little taller, but in this case it's significantly taller. And we remember that the phrenic nerves run anterior to the right superior, right inferior pulmonary veins, and it wraps around the SVC in the lateral wall of the right atrium. So this region over here is Waterston's groove. When a surgeon is entering the left atrium, they go right between these veins in the right atrium, and the vein kind of hugs in that neighborhood. And remember what I said about the depth of an ablation lesion. So if we're giving an ablation and we're just inside of the right superior pulmonary vein, and particularly if a cryo balloon is used, because those can slip in the vein a little bit more than an ablation catheter, then we can stun the phrenic nerve. And the maneuver is a sniff test under fluoroscopy. The patient takes a big breath in. The left hemidiaphragm moves as expected. The right one, because of the injured nerve, does not. So elevated hemidiaphragm, sniff test. Symptoms may be asymptomatic, may be dyspnea, usually resolves on its own, but it can take a year. It can be a very slow recovery. And typically it's once a diagnosis is made, it's observation, and occasionally some sort of treatment is indicated. Now, what about this one? This was another one of the pre-test questions. And before we go into these options, this x-ray is different than the last one. It's harder to see. But what's the abnormality on the x-ray? I want you to focus right here. Notice how this color is the same as this dark stripe here and dark stripe here. So this is a pneumopericardium. And if you see a pneumopericardium on an x-ray, on a patient who's had an ablation, it is usually a medical emergency. Pneumopericardium on an x-ray is usually a medical emergency. The first thing you want to do is call the person who did the procedure. If they did percutaneous epicardial access, where a sheath is placed under the diaphragm into the pericardial space, which we do sometimes for ablation, then occasionally there can be air and it's not an urgency. But for the vast majority of ablations, it is. And here's why. There's a close relationship between the left atrium and the esophagus. And if there's injury to the esophagus, as shown here in this barium swallow, you see barium coming out, then typically 2 weeks or so after the procedure, the contents of the esophagus first, in this case, come into the oblique sinus, and then they can go into the left atrium, and you can get air and gastric juices in the left atrium and get stroke, air embolism, and it's a severe dire thing, and this is typically treated with surgery. So the patient who has a pneumopericardium is admitted for observation. The important relationship here is that between the left atrium and the esophagus, typically there's just an oblique sinus. So if you were to slip your hand under the heart and just slide it all the way up, it will go through into the oblique sinus, and this distance is small. The blood supply to the esophagus is anterior to it. And so if ablative lesions affect the esophagus, then we can injure it. Now you might say, well, why doesn't that happen right away? Why didn't you know about it in the procedure? Well, the thought is what happens is because of the injury to the blood supply, there's an inflammatory process, a delayed effect, and slow disintegration, inflammation, injury to the anterior esophageal wall. And over time, there's an anterior erosion, so the damage actually goes from esophagus to left atrium. So what would a patient present with? Typically, it's 1 to 3 weeks after ablation. Inflammation is important. They will have fevers, SED rate, elevated white count, one of these things. So it's important to check for white cell count and SED rate. They may have symptoms of endocarditis. They may have neurologic symptoms. I'm spending a lot of time talking about it so you'll be aware of it, but it's exceedingly rare. Very, very rare, but important to be aware of. And during the procedure, a number of steps are now taken to avoid it. A temperature probe in the esophagus, monitoring the position of it, lowering energy, and these things appear to be effective, but because the incidence is so rare, it's hard to know that we've eliminated it. This image just again to show back of the left atrium. Here's the right inferior pulmonary vein, left inferior pulmonary vein. Here's the esophagus right behind it. So post-ablation care complications. Anticoagulation, typically for 3 months to allow the endothelium of the atrium to heal. For patients who have an elevated CHA2DS2-VASc score, as we heard about, we treat longer and in fact continue anticoagulation for someone who's at risk for thromboembolism. For recurrent atrial fibrillation, as I mentioned, antiarrhythmic drugs early for 2 to 3 months and then discontinue. Pulmonary vein stenosis, injury to the veins because of ablation, it's now relatively uncommon. What do you need to know about it? The patient may present with a pneumonia. They may present with what looks like a pulmonary embolus and a positive VQ scan because blood is not flowing out of that pulmonary vein, and so you get congestion in that part of the lung. You get diminished flow, but it can still ventilate. So it is often misdiagnosed. So if someone early after ablation has pneumonia, has what looks like a PE, just make sure to check for possible PV stenosis, and you would do that with a CT scan that will show you the pulmonary veins clearly. Phrenic nerve injury, we talked about, exceedingly rare esophageal fistula, but important to identify. Complications, so pulmonary vein stenosis, this from a large meta-analysis, 1.6%. Tamponade, also anywhere from 0.7 to 2%, depending on the series. Periprocedural stroke, quite rare. Death, exceedingly rare. Common complications, up to 5%. Usually vascular access in anticoagulated patients, hematoma, pseudoaneurysm. In our practice, we will typically do these with patients while their INR is 2.5 or less. And it's often simpler to keep them on warfarin than to try to stop it and bridge and associated with lower complications. So 57-year-old man with borderline hypertension. I think we asked this one already, so I'm going to jump ahead. 54-year-old otherwise healthy woman presents following 3 highly symptomatic episodes of atrial fibrillation. And here we are asking which ECG finding is most likely to require discontinuation. Rather than asking you through it, I just want to walk through the key points regarding antiarrhythmic drugs. And that is the following. Class 1A drugs, which we rarely use now, the reason being most patients would rather have atrial fibrillation than, say, continuous diarrhea from quinidine. But if we use, for example, disopyramide in a HOCM patient, we monitor the QT interval and we want it to be less than 500 milliseconds. The key point about these rarely used drugs is that they enhance AV nodal conduction. So if we organize the atrial rhythm from fibrillation to flutter, we may get very rapid conduction. Again, not commonly used, but we'd want to give something to slow AV nodal conduction first. 1C drugs, propafenone, flecainide, sodium channel blockers. They slow AV conduction some. We monitored the QRS duration. So we expect in these that the QRS will widen. So it won't be the QT, but the QRS. And if we don't see any widening, it's reasonable to go up in the dose. I'd like to see at least a 10% widening to say we're getting some electrophysiologic effect. It's a first choice in normal heart, but we avoid it in coronary disease or reduced ejection fraction. So I'm just going to go back a slide. That's why for this patient who's going to start flecainide, the QRS is 90, and certainly if it was more than 120, we would stop. That's a more than 25% widening. And that's the main thing we're looking for with flecainide and propafenone. And if we don't see it go to at least 100 and the patient's having breakthroughs, I would think about going up on the dose. Then on the table, class 3 drugs are amiodarone, sotalol, or dofetilide. These are the first choice with LV dysfunction in post-MI patients. We want the QT to be less than 500. If there's a pre-existing bundle, we let it go up to 550. for Sotalol and dofetilide. Amiodarone very rarely causes proarrhythmia, so we'll sometimes be a little more generous with that. But strictly speaking, 550 is the upper limit with a bundle of what we'll accept. So another case, 84-year-old man presents after complaining of feeling unwell for several months with fatigue and palpitations. He was seen by his primary MD, who put him on a medical regimen, and you can see his medications here: Coreg, Crestor, Lasix, lisinopril, warfarin, potassium. He's got obstructive sleep apnea on CPAP, hypertension, hyperlipidemia, and reflux. An examination, his blood pressure is 95/65, heart rate 88, moderately enlarged PMI. His echo shows us an ejection fraction of 30 to 35%. Here's just tracing from his Holter. The basic rhythm is atrial fibrillation. He complains of palpitations and no energy throughout. We decide to restore sinus rhythm. Which drug is the best drug for this patient? Flecainide, dronedarone, Sotalol, or amiodarone? Great. So that's correct, and that just highlights the strategies for rhythm control. In the setting of structural heart disease, as we reviewed, in this patient there's heart failure present, so our choices are amiodarone and dofetilide. Dofetilide was not one of the choices in the STEM, so we go with amiodarone. So a few points about new onset atrial fibrillation. A patient who's not previously known to have the arrhythmia. First, it's important that we put on our medicine hat and think about what are all the potential causes of it. It's well recognized that thyroid abnormalities can cause atrial fibrillation, and every patient who initially presents with atrial fibrillation should have a thyroid check, a thyroid blood test to check levels. Alcohol use can cause atrial fibrillation, and don't forget about the so-called holiday heart. The 22-year-old college kid who has just a few too many beers and everything else mixed in, who all of a sudden has a racing heartbeat and presents with atrial fibrillation. Treatment there, of course, is avoidance of alcohol. Sleep apnea is an important one to be identified, and roughly 50% of patients with atrial fibrillation will have sleep apnea. And when you think about it, at night, if you have sleep apnea, obstructive sleep apnea with snoring, during apneic episodes, oxygen saturation levels drop. The chest cavity is attempting to make an excursion to expand, which puts an actual pressure gradient across the wall of the atria. So you've got mechanical stress, you have hypoxemia, you have a surge in adrenaline, just as anybody would if someone came up behind you and put their hand over your nose and mouth. It's the same functional thing. And all those factors together strongly promote arrhythmia, an inflammatory state, marked activation of the autonomic nerves, sympathetic tone when measured with microneurography is through the roof. So very strong, very treatable condition with no side effects to speak of from the treatment. Hypertension, we all recognize, is closely associated with the cause of atrial fibrillation, not just a risk factor for stroke. And medical obesity is also associated with atrial fibrillation, one of the hardest conditions to treat, yet most important since it affects so many other factors. For post-operative, post-surgical atrial fibrillation, what do the guidelines tell us? I just distilled the key points here to summarize them for you. Class 1 indication, treat with beta blocker. If contraindicated, use a non-hydropyridine calcium blocker. Class 2A indications, preoperative amiodarone reduces postoperative atrial fibrillation. So this is certainly in cardiac surgical patients where the risk of post-op atrial fibrillation is 25 to 35%. If you start it for a week ahead, the risk does go way down, although it's not commonly used because of potential side effects and complexities in administration. Ibudilide or cardioversion are reasonable for postoperative atrial fibrillation. Rate control with anticoagulation and cardioversion, if it doesn't revert spontaneously during follow-up, is also reasonable. Class 2B would be Sotalol or colchicine. I'll kind of conclude with two other special cases. One is a cardioversion case, and I'll ask you a question on this. 76-year-old man with hypertension, no coronary or vascular disease, congestive heart failure, diabetes, or stroke history, presents with 14 hours of clear onset palpitations. An ECG confirms atrial fibrillation. Biochemistry and thyroid function are normal. Per the guidelines, what do we do next? Number 1, TE if negative cardiovert and oral anticoagulation for 4 weeks. Number 2, TEE if negative heparin, cardiovert, oral anticoagulation for 4 weeks. Number 3, heparin, cardiovert, oral anticoagulation for 4 weeks. Number 4, heparin, cardiovert, no long-term oral anticoagulation. Okay, great. I think most of you are familiar with this. This looks busy, but I'm going to walk you through it and then distill it down to the 3 main concepts that really come out of this. So if someone comes for a cardioversion, if the atrial fibrillation is less than 48 hours, and we're really sure it's recent, then you give heparin and cardiovert. Now you may say, what does the heparin do? And the answer is, we have no evidence, but there's some thought that there may be a pro-coagulant state from the shock, from the cardioversion. And so when the gurus got together and put the guidelines together, what's the risk of giving it tiny? Let's give it. Maybe there's some smoke or some pre-thrombus or something that we're not looking at. If you get sinus rhythm, so idea, whenever you cardivert, give heparin, cardiovert. If you get sinus rhythm, are risk factors present? If none, you're done. If they are present, then anticoagulate for 4 weeks. Now, what if it's longer than 48 hours? You can either do the conventional strategy, which is 3 weeks of anticoagulation, heparin, cardiovert, or you can do the echo strategy, and if you're British, it's a TOE. So do a transesophageal echo. If there's no thrombus, heparin, cardiovert. And then once a cardioversion is done again, if you've gone through this route of longer than 48 hours, everyone gets 4 weeks. And then long-term, if it's indicated, and that's determined again by the risk factors that have already been reviewed. So what are the key points? Number 1, everyone gets heparin before cardioversion. Number 2, give 4 weeks of oral anticoagulation after cardioversion unless both of these are true. The episode is clearly less than 48 hours. There are no stroke risk factors present. Easy enough to remember, and of course to make it more confusing, there have been roughly a half dozen atrial fibrillation guidelines. ACC-AHA, European guidelines, Canadian guidelines, CHEST. So everyone has an opinion, and unfortunately, while there's a lot of consistency, there's non-uniformity. So here, the American College of Chest Physicians would say, always give 4 weeks, and I think you can't be faulted for it. You won't be tested on this for boards. In practice, I would err on the side of anticoagulation for 4 weeks. The risk for 4 weeks is small, and anything to avoid a stroke with a small risk seems worthwhile. The third point is, again, if the atrial fibrillation is present more than 48 hours, the patients either need 3 weeks of anticoagulation or a TEE, and we anticoagulate afterwards. And I'm not going to talk about it at any length, but if you're trying to decide whether it's flutter or fibrillation, well, if you're going to do an ablation, it's good to know. If you're going to do a cardioversion, it doesn't matter. You'll anticoagulate the same way. So for cardioversion, flutter equals fib. It's the same in terms of stroke prevention. Once again, stroke prevention, flutter equals fib. And then my closing case, a classic that you may or may not see in practice, but you'll almost certainly see on boards. 38-year-old man presents to the emergency room complaining of palpitations. He denies chest pain, syncope, presyncope, substance abuse, any medical history, blood pressure is okay. What are you going to give him? DIG, adenosine, verapamil, ibutylide, or esmolol? Here's his ECG. And if you haven't seen this ECG yet today, and you may not have, I predict you'll probably see it once or twice more times today as my colleagues give their talks. So if you miss it this time, you'll get more turns. Great. So the vast majority of people recognize, what's the rhythm? AFib with Wolff-Parkinson-White. And the key to notice is that it's wide, so it's kind of ugly. It's variable. And in some cases more than others, there's varying degrees of how wide the complexes are. where you get some very wide ones, some sort of wide ones, and usually in most of them that you would see, there'll be some skinny ones as well. And it's a function of how many complexes are going down the pathway versus how many are going down the AV node. So Wolff-Parkinson-White syndrome and atrial fibrillation, don't give adenosine. Adenosine will block the node, everything goes down the pathway, and the arrhythmia becomes faster. Ibutylide and procainamide are the drugs that are reasonable to use. And I think with that, I will stop. Thank you for your attention.
Okay, so there's been a few questions that have come in, Paul, and one of them, a few questions about your approach to specifically anticoagulation, but maybe, again, review post-op AFib.
Yeah. So generally with post-operative atrial fibrillation, if you can cardiovert within 12 to 24 hours, you don't even have to do more than give the heparin for the cardioversion. Most of the patients who I see for post-operative atrial fibrillation have had cardiac surgery. Cardiac surgeons are generally fine with anticoagulation, so we'll often give the anticoagulation. If we restore sinus rhythm and we know it's been short duration, then the patient doesn't need to go home with anticoagulation unless the cardiac surgery requires anticoagulation. If it's non-cardiac surgery and a patient has atrial fibrillation, there we're sort of dealing with competing risks. And if the surgeon is very concerned about anticoagulation and we can cardiovert within 12 to 24 hours, that's an attractive strategy. If they're not medically stable for cardioversion, if they're too sick from their gastric or whatever kind of surgery it was, then we'll use rate control. And bear in mind that the risk of stroke from atrial fibrillation depends on the CHADS-VASc score. For most patients, although it can range from 0 to 20%, but usually it's in the 6 to 8% range per year. And so if we're talking about a very high risk of bleeding right after surgery, neurosurgery, for example, where the consequences would be grave, then typically we will rate control, hold off on anticoagulation until the surgeons are comfortable with it, and then typically start heparin without a bolus once it's safe, and then just use a rate control and anticoagulation until we can get farther out from the procedure. Generally, if it's post-operative, I think it makes sense to try to restore sinus rhythm, whether it's in the hospital or at a follow-up visit if they're still in fibrillation. And often, as you know, if there's that acute stressor causing it, it may stop on its own.
Okay. You mentioned the different ECG changes that can occur with the antiarrhythmic drugs.
Yes.
So for atrial fibrillation, are there any that you're comfortable starting as an outpatient basis and not bringing them into the hospital?
Yeah, great question. And the guidelines have spoken about this as well. First, the ones that are not debatable: dofetilide, Ticasin, inpatient, mandated by FDA. If you do it as an outpatient, you're going against what the FDA has prescribed, and if there's a problem, it's a big deal. So Ticasin is an inpatient start. The ones that are most commonly used as an outpatient would be flecainide or propafenone, the 1C drugs in a normal heart. And then it's good to think about when does it make sense and when should you maybe be more concerned. What the drugs do that could cause problems would be conduction system disease, because it's going to widen the QRS. So if someone has a bundle of 150 milliseconds and you don't know if this drug is going to give them AV block, and I mean, you may not want to use it in the first place, but if someone has a very wide QRS and a pre-existing bundle, that may not be the person to start as an outpatient in those drugs. Of course, the assumption with those two drugs is that the person doesn't have congestive heart failure or coronary disease. If they have risk factors for coronary disease, very reasonable to do a treadmill test, by the way, and that can be done after you've given them the medication if they've had no coronary symptoms, because you're talking about a sort of few days overlap. But again, those are the two drugs that are most commonly started as an outpatient. Bradycardia would be the other potential thing. So to summarize then, for propafenone or Rhythmol, reasonable to start as outpatient. If it's going to be flecainide, maybe 50 milligrams twice daily, 75, 100, and then titrate it up. Check ECGs at 3-day intervals as an outpatient, see about QRS increase, follow up with a treadmill. And Sotalol, some people do, but that's controversial.
How about amio?
Amiodarone, yeah, thank you. Amiodarone is probably one of the safest to start as an outpatient. And there we'll typically just start 200 a day and let it build up, and it'll be a month to 2 months before it builds up. We typically will check labs, liver function, CBC. If the patient is on liver function, CBC, thyroid function, chest x-ray, pulmonary function test as a baseline. If the patient is on concomitant Coumadin, we would lower that dose by roughly 50% because of the interaction between amiodarone and warfarin. So a real important thing, amiodarone, warfarin interaction that you'll want to remember.
Topic near and dear to my heart. So how much LVH does it take before you start altering your antiarrhythmic drug choice? So maybe not due to HCM, which is a pathologic myocardium, but say, hypertensive, hypertrophy, those kind of things.
Yeah, so the old guidelines actually had a number in them, and now the newer guidelines have not included that number, so I guess we have a little bit of wiggle room. But generally more than 15 millimeters. If you see a strain pattern on the ECG, then that's a good reason to be concerned about repolarization. The echo numbers are a little harder for me to come up with a solid number. Again, because they were in guidelines, they were removed from guidelines.
Yeah, okay. How do you approach cardioversion in the setting of a TEE that doesn't show thrombus but shows smoke?
Cardiovert.
Cardiovert, and then what do you do with the anticoagulation?
And then that's somebody who I would anticoagulate for 4 weeks afterwards. But if you're really sure it's all smoke and no thrombus, then you give the heparin, Cardiovert, and then keep them covered. So a nice strategy there, by the way, because if you're going to give warfarin, you have to wait for that to become therapeutic. So I'm sure probably many people in this room already have adopted the practice of give heparin, and then you can give a NOAC, and within a couple of hours, they're therapeutic. And it makes a simple transition.
Yeah, so that was one of the other questions, which is a good one, is that can you use a NOAC up front, kind of pre-cardioversion, and then, or switch them from warfarin to NOAC? How do you handle that kind of new environment we're in?
Yeah, so if they're not on warfarin, it's fairly straightforward. If someone is coming for a cardioversion, you can give the NOAC ahead of the cardioversion. I'd probably still give one shot of IV heparin at the time, do the cardioversion, continue the NOAC for the expected duration. There have been sub-studies now from a number of the NOACs from their large prospective randomized trials that got their indication for atrial fibrillation, and they seem to be just fine for cardioversion. The results are essentially equivalent to warfarin. I mean, these generally have a couple thousand patients out of these trials with 15 to 18,000, so they're not as big. But I think the general challenge with the NOACs that leave everyone a little uncomfortable is someone's on a NOAC and you need to do a cardioversion and you wonder whether they've been on it every day for the previous 3 or 4 weeks, right? And that's where it's harder, and there's not a definitive guideline, and when in doubt, do the TEE.
Yeah, and so in our practice in the emergency department, we have a protocol where patients that come in with new onset AFib, they get put on a NOAC and dismissed as an outpatient as long as they don't, as long as they're hemodynamically stable and not highly symptomatic. And so then they have an outpatient follow-up visit in a few days to determine long-term anticoagulation needs and cardioversion needs. But we give a NOAC up front because of the rapid onset of action.
Yeah.